Good morning. Happy Thursday. We'll get started in just a second. So thank you for joining us to our session today on shared sanitation. My name is Sarah Lebu. I am a postdoctoral research associate here at UNC, and I'm excited to have this conversation around shared sanitation with you today. So we have an exciting lineup for you. But first, to set the agenda, set the stage, I'm going to introduce Sam Drago from WhatsApp, who will tell us why we're here today. So welcome, Sam.
Great. Okay, thank you, Sarah, and thanks to all of you for coming. There were a lot of really interesting sessions this morning. We appreciate that you came to this one, and we're going to make it worth your while. So my role here is to really set the scene for the session, talk you through the agenda and what to expect, but also put that agenda in context. And start by putting it out there quite nakedly that we have a proposition that we're looking to drive through in this session, and that is that we have the evidence base, we have the collective knowledge to deliver shared sanitation at scale now, and the time for seeking justifications for that really is past, and we're going to set that out as we move through. But you might have questions against that, and we've designed the session to systematically address each of those questions. Okay, so beginning first of all, maybe just with some context on the practical need for shared sanitation. Now that's question number one. Is there a practical need for shared sanitation? And many of you will know that these discussions are taking place in the context of continued large-scale rural to urban migration, and many of these populations settling on the periphery of cities in informal, high-density settlements. Countries across Africa and Asia have large numbers of people in these settlements depending on shared sanitation, and that is a total of 1 billion people globally. I want you to keep that number in mind as we move through. 1 billion people depending on shared sanitation. This is not a niche concern. This clearly needs to be addressed, and shared sanitation is the only option for these groups. There's no practical alternative to shared sanitation in many cases in densely populated, low-income urban settlements because of spatial constraints, because of financial constraints, socioeconomic constraints. So these people will be using shared sanitation. The only question is, will it be of sufficient quality to deliver health impact, quality of life impact, dignity, security, privacy, all of these first-level concerns. So that comes then to the first part of our session. Is there an evidence base that shared sanitation can deliver these impacts? And this is where the discussion has really moved on. So some of you may have been in sessions in the past at UNC around shared sanitation, but recently we have truly groundbreaking new evidence, which Joe Brown is going to present from the MAPSAN trial, that shows that shared sanitation can deliver health impact. So shared sanitation interventions delivered in Maputo in Mozambique have delivered a 30% reduction in child stunting. That is linked to a reduction in exposure to enteric pathogens. And there is also very strong evidence around the quality of life benefits from the same intervention and other interventions of shared sanitation for women and girls. So it is a complete evidence base. So that's part one that we're going to set out. The second question you might raise is, but how then do we measure and define high quality shared sanitation? And this has been an ongoing challenge for the sector. But again, we are progressively getting to grips with this, and there have been foundational studies like QUIS, Quality Indicators for Shared Sanitation. You're going to hear in this session from research led by Musa Manga and also John Akadago, Habitat for Humanity International. They'll be speaking about the work that is ongoing now to help us measure high quality shared sanitation and potentially inform global monitoring frameworks. Then the third question you might ask is, but do we have the knowledge and the capability to deliver shared sanitation at scale? And here again, you won't be surprised that our answer is yes. We have a collective body of experience, and you're going to hear from those actors today. So we have Kampala Capital City Authority, one of the cities that is leading the way in delivering shared sanitation. Fresh Life, because container-based sanitation is a key part of this piece, and from WhatsApp, where we'll share our reflections on the intervention in Maputo that has delivered these health impacts. So that's the basic case. We have the evidence, we know how to monitor it, we know how to deliver it, but still the level of investment in shared sanitation, we reckon is far too low. And that's where we're going to move in the panel discussion. We're going to have a discussion, and we'd love to hear from all of you as well around how we can mobilise this evidence to get more momentum around shared sanitation at scale. And that's in the current context. Recognising the challenge of financing shared sanitation, it's going to need more than engaging with the wash sector. We're going to need to engage with other sectors around child development, health, and so forth, leveraging this new evidence. So how do we do that? And that's going to be the final part of the panel. So that's our case, which we're going to test as we run through, but I do want to say that we are open to challenge. So we want to hear from you, we want to hear your critiques and challenges to what we're presenting, and we're going to keep enough space in this final discussion so that we can have more of a dialogue around next steps. That's all I wanted to say in this opening, but I will hand back to Sarah. We're going to go into the presentations.
Thank you, Sam. So now we're going to move into a series of rapid-fire presentations, like Sam said. You're going to hear from 4 different speakers, each going over a range of different topics on shared sanitation. So you'll hear speakers talking about evidence around health outcomes, around policy, around implementation of shared sanitation. So to start us off, I'm delighted to introduce Joe Brown. You probably all know Joe. Joe is the acting director of the Water Institute and also a professor at UNC. So Joe, please.
Thank you, Sarah. Thanks, Sam. Good morning, everybody. As Sam indicated, I'll be talking through some of the results from the MAPSAN trial that we think are important in framing the discussions around shared sanitation going forward. I'm not going to discuss the whole evidence base for shared sanitation as an impactful intervention, but just the results from this trial. So, thank you to USAID. Thank you to the Gates Foundation. This study took place in Maputo and informal communities that look like this. And our primary questions were, do multifamily or compound urban sanitation facilities as delivered by WASUP, do they impact on enteric infections, growth, diarrhea, and environmental transmission of pathogens, as well as quality of life measures? And here we are at the bottom of Mozambique there in Maputo. The existing shared sanitation infrastructure that serves compounds in this area kind of looks like this, breeze block construction, pretty basic. This infrastructure is not very good at containing fecal waste. There's a lot of uncontained wastewater and fecal waste that makes its way into the living environments of people there. The drop holes are pretty basic. This is the intervention. So this is a communal sanitation block that's developed by WASUP. These are site design and site built specifically to serve environments like this. They have lots of amenities, including things like rainwater storage tank, sinks for hand washing, sex segregated latrine cabins, water storage tanks. They've been installing these since about 2009, and they're customizable. They're sized to fit the number of people that they're serving. They also have a more basic model. This is referred to as a shared latrine. It serves smaller numbers of people. It lacks some amenities, typically smaller compounds, even a couple of families. They're much cheaper. These are, where the waste goes, these are septic tanks, so the solids go to a subsurface tank where the solids are retained. The aqueous effluent goes to a soak-away pit, which looks like this. This is a lined soak-away pit where the aqueous effluent would go. And the sites where we were looking at both existing sanitation as well as the new sanitation is developed by WASUP is here. So control compounds in blue, intervention compounds in red. They are, some of them quite close together. They're in the same neighborhoods of central Maputo. And for the stool samples, we measured enteric pathogens. I won't go through all the methods, but we took stool samples from well over 1,000 children in both of these groups and looked at the frequency of enteric pathogen detection as a proxy for infection. I'm sorry that this is a little bit, the formatting's a little messed up, but the overall design of the trial was we did a baseline before implementation, both in a group that would receive the intervention and a control group that's frequency matched, and it has many of the same characteristics. We went back 12 months, 24 months, and 60 months following the implementation of the intervention. It's an open cohort, so people move into and out of these compounds. And I'm just going to talk about the results at 60 months post-intervention. And as Sam indicated, we noted a 31% reduction in stunting associated with the intervention. And after controlling for every possible other factor that we could measure that could potentially explain this difference, this is the height for age Z-score histogram, both for the controls in orange and the intervention in purple. And you see just a clear rightward shift in linear growth among kids who are spending their entire lives exposed to this latrine. So basically sanitation from birth is resulting in dramatically increased growth. This is among, this magnitude of effect is consistent with some of our most efficacious interventions for stunting reduction. So that was interesting, right? So we see a big difference in growth, but we also noted that there was a very large difference in the prevalence of detection of enteric pathogens between these two groups as well, consistent with our hypothesis that enteric pathogen exposure and infection repeatedly in early life has implications for nutritional status later on. So you probably can't see all these and make these out, but intervention is orange, green is control, and we see very large differences in things like Shigella, enterotoxic genetic E. coli, Ascaris, Giardia, and some of the other more important pathogens that we follow in things like this. And again, this is about 1,100 children. For those epidemiologists in the room, these are the adjusted prevalence ratios for all of these different pathogens. The ones in orange are ones where we see large reductions. Trichuris, enterotoxigenic E. coli, Shigella, Ascaris are among the more important ones. Even harder to see from where you sit is disaggregating the data based on the type of intervention. So communal sanitation blocks, the larger ones, versus shared latrines, the smaller ones. And what it looks like to us is that both for the enteric pathogen prevalence as well as the growth, it looks like there's a slightly larger effect among the shared latrines. You have to maybe trust me when I say that instead of trying to interpret that in real time. Yeah, but it's directionally consistent where controls are in green, communal sanitation blocks, the larger ones are in orange, and the shared latrines are in purple. And it's a very consistent theme. So this may have some bearing on our discussion of shared sanitation. We're seeing that basically the fewer people that are sharing them, the greater the impact in this setting, right? Which I think is consistent with some of our other hypotheses around this. So we see clear improvements in growth and lower pathogen exposure, and some evidence of greater impacts among those smaller compounds, okay? Finally, I just want to say something about our quality of life measures. There's a whole, we'll be publishing papers on this study for many years to come, so there's a lot of other things to say about this. That's just the most important findings. Some of the other results around quality of life, and this is led by Ian Ross at LSHGM, looking at the SANQUAL-5 index, which measures attributes of disgust, disease, privacy, shame, and safety that are weighted in specific ways. And in 2019, so 4 years post-intervention, we surveyed individuals both in the intervention compounds and in controls, using and used regression analysis to measure the SANQUAL index, Sanitation Visual Analog Scale, and the WHO-5 Mental Wellbeing Index. And I'll skip that and just say that we saw a very, very large difference between these two groups in terms of quality of life measures and what people reported around all of the other non-enteric and non-growth measures. So 1.6 standard deviations difference in SANQUAL-5. 1.3 standard deviation difference in Sanitation Visual Analog Scale, and a 0.2 standard deviation difference in the WHO-5 Mental Wellbeing Scale at the margin of significance. So quality of life is also a very, very important thing here. And that's when you talk to people who live in these settings, what you hear from them is that these interventions, this infrastructure is really very meaningful when it comes to improving quality of life, security, safety, dignity, and all the other things that people actually value sanitation for. So with that, I will cede the floor back to Sarah, and I appreciate it. Thank you.
Thank you, Joe. So a key takeaway for me is that we can see consistently positive health outcomes where users, rely on shared sanitation. But then how do we separate the wheat from the chaff? How do we know what's high quality and what's low quality? So I would like to introduce our second speaker, Dr. Musa Manga. Dr. Manga is going to talk about how we can distinguish between high quality shared sanitation versus the low quality ones. Dr. Manga.
Thank you so much, Sarah. Thank you, Joe, for setting the platform for me. So we took a study to understand how do we separate, or how do we assess the quality of shared sanitation. We all know, everyone talks about shared sanitation, but we want to get out of this room knowing we shouldn't use that again. We need to be talking about quality shared sanitation. So what we did here, we conducted a study to see how do we measure the quality of shared sanitation service. And we did this in Kenya, Uganda, and India. So to give you a background and a motivation to this, sanitation access remains a challenge in most of the populated urban areas. And the reason this is happening is because it's really not visible to have individual households in these communities. All that is coming from the competing needs for available spaces, the incestual and tenure, and all other factors. We've done a lot of work on this, and we published it to talk about all these competing needs in these urban areas. What we need to know in this context, because people can't rely on individual household toilets, what they have decided is to rely on shared sanitation facilities. And as we speak, the GMP in the recent global sanitation monitoring, they indicated that about 570 million people rely on shared sanitation facilities. This means 1 in 4 people in 33 countries actually relying on this. And in developing countries, this is a common kind of thing. So the question is, what is shared? Because they keep talking about this. If I show you this, I'm showing you what they look at shared. Across the world, there's a wide range of shared facilities, and these vary in quality. And that would be the environmental type of technology, the number of users, cleanliness, hygiene levels, and the operational and maintenance practices. We don't need to be talking about shared. We need to be talking about the quite shared, because if we say shared as an umbrella, we're actually saying everything is bad, and that's not true. What we did for us to do this study, we actually thought about this. We noticed there is no standard criteria for distinguishing between high quality and low quality shared sanitation. And the GMP classifies all shared sanitation as limited, and they do not meet the criteria for best sanitation. They say that's all limited. We say they're actually looking at this umbrella, and because of this, investment in shared sanitation is actually not going forward because everyone feels like that's not really, we need to focus on basic. So for that reason, we spent some time digging into literature. What we find that shared sanitation is actually important. And there's even evidence that suggests it's even better than individual kind of household toilets. For that reason, we conducted a systematic literature review in 2023, and we put all together over 300 papers to understand exactly how do we identify indicators to separate the quality of shared sanitation. We published most of this work, and we've really shared all that. But what do we take from this work? What we get from this work, we identified some of these key indicators. What we see, the key indicators, 1, does the facility ensure hygienic separation of human excreta from the human contact? The other one, we also see is the sanitation facility shared by multiple households. If that's yes, we also go and say, is the facility shared by less than 5 households or more people, or whichever is fewer? And then the other one, is the sanitation facility located within the shared compound? If all this is yes, we go further to say, is the shared facility accessible for all, including people with disabilities? And then we also look at, is the shared facility lockable and safe? And the last one, is the facility cleanliness a shared responsibility? We have a kind of designated role. If all this is yes, that we say is going to be high quality. That's what we suggested in those indicators. If it's no to some of those, you're likely to have a low quality shared sanitation. And then some of it is unimproved. Now, this is based on what we did in the review. We never had real evidence. For that reason, we said we need to set up a study to really understand if these indicators are actually making sense, if they're even reliable. So what we did, we set objectives to go and do this study. One of the things we did was to test and validate a set of indicators that are actually valid, reliable, and visible for assessing the quality of shared sanitation facilities. The other one was to refine and develop the shared sanitation quality scale to assess across various countries, to give one scale that we can use. And the third one was to develop recommendations from field testing methodologies that can be used assessing the quality of shared sanitation globally. To do that, we actually went to 3 countries. We conducted a cross-sectional study in May and August 2025, and this was in India, Kenya, Uganda. But we did a multi-stage cluster sampling approach where we start from the country, we go to settlement, sub-settlement, have villages or community level. And then we collected data, and the data we collected involved transect walks to know the systems they have, did some key informants interviews, had household surveys. But all this, we are targeting adult users of these shared facilities. In India, we did our work in New Delhi, and we looked at the north and central and south. And we had about 1,900 samples, surveys conducted there. In Kampala, we worked in Kawempe, Nakawa, Machinde, Rubaga, and we had about 1,822. In Nairobi, we just worked in Kibera, but we want to go to Rigori pilot what we've picked up to see in Makerere. So that's what we did. And when we got all this data, we did the analysis. We started with the descriptive analysis to understand the household demographics and facilities and practices. In here, we're looking at the sanitation facilities and the sanitation practices. But also did regression analysis to examine the predictors of shared sanitation performance and user satisfaction. In here, we looked at the effect of a facility condition and practice on facility performance. The same thing we did for user satisfaction. And then we had to do the scale development to run statistical analysis to show evidence of the scale validity and reliability. In here, we did the item development and also did the validity and reliable testing. So what did we see? The first result I'm showing you here is we try to look at the systems that people are sharing. In here in India, we saw that most of those 35% are sharing septic tanks, but 65 were connected to sewers. And then in Kenya, we saw 56 were using clean with lab, and 18 were using pore fresh. And in Uganda, the majority of them were using fresh to piped sewer, but they had 29 on septic tanks and other. So that's one thing we saw. But also we wanted to know the people sharing these facilities. In India, we see them ranging between, households. We're talking about 2 households to that, and in Kenya, it's ranging between almost 5 to 8 and so on. And the average is about 6 households. And the number of people sharing is the same thing, and so ranging between around 12 to around 20. So, and those are the numbers people sharing. The same thing we did for facility conditions in here, and we saw roughly the user patterns and what we're seeing here. You probably see that, so we see the kind of users of these facilities in the same compound, and you see most of people in India in the same compound. And then we also did the same thing for accessibility. We look at people in Kenya and percentage of facilities, but we're also looking at accessible to all, accessible 24/7, and trying to look at those within the compound. And we still see that, at least in India, we see most of those actually are happening. The same thing we did for safety and privacy. We also looked at having light availability, functional door locks to make sure they're meeting that. The same thing for cleaning frequency. We probably had to look at in the different countries to see if it's cleaned once or more per day, a few times per week, or once a week or less. And we try to look at also the people sharing individual responsibility in cleaning. So we took this, but this was to get a feel of what they're doing. So what we did then, we did some kind of, these facility conditions and user practices predict performance. So we had to come up with a performance kind of index. So what we did here, we look at all the facility conditions, the user practices, the household characteristics, and we came up with a facility performance index, which puts in accessibility, cleanliness, and privacy. So what we did then, we had to perform some kind of prediction to see which ones predict better. So what we did here is we first looked at technology and taking the pit latrine with a reference lab. What we see that the facility performance increases when people are using pour-flush septic tanks, piped systems, and so on. The other thing we also did was to look at the location, material for cleaning, and materials for safety. The same thing we saw that if the location is inside the compound, the performance is actually better. If you have if you have water for cleaning within the facility, the performance is better. If you have a log and light, we see more performance coming through. And the other one we looked at was on cleaning and maintenance practices. We looked at the users, main cleaners, and so on. And what we see, you probably see if it's not shared by public users, the performance is better. We also saw that if it's cleaned jointly by users, the performance was better. If it's cleaned frequently, the performance is better. And if it's not paid for to use it, it's better. So that was quite exciting for us. So what we did, we then stepped back to think about the number of people using and the households to see how that performs. So what you see in the first one, I'm showing the performance index here, and I'm showing the number of households using the facility. Here, the same thing I'm doing, but I'm showing the number of people using the facility. What you notice that those of which we've noted with blue are those that we had enough sample to make sure we can compare them. What we see that every time the performance decreases when you have 5 or more households. And when you look at people, every time they're more than 22, we see a decrease in the performance. But the appropriate cutoff is going to be between 5 and 10 and 20 and 30. So we're doing more, kind of going to pilot more to get more data to keep looking at this, to have the real cutoff for this. The other thing we did, we looked at predicting the sanitation quality of life. So we did the same thing. We had the facility condition, user practices, and household characteristics. But we then built a matrix, which is close to what Joe talked about previously. And then we wanted to do the assessment. The results we see in here are not different from what we saw in the previous one. So we actually saw that when those are met, even the quality of life is actually met. Now, to take you to where we're supposed to be is what are these indexes that we have to use? So we did a factorial analysis. We spent some time digging into the data to do a principal component analysis. So what we did is we defined the key domains. And these key domains we defined was safety, maintenance, accessibility, and usage. So what we then did from that, we ensured if we have liability and observations across the domains. And we try to check to see if really this is going to be reliable as we try to go forward in cutting it off. The other thing we did then was to now assess the overlaying structure of the data. And we want to ask ourselves, do the survey questions belong in the right domains, the ones we put there? So we did a principal component analysis to see where do they lie. Are they within the domain? And then once we did that, we then had to determine the most optimum factors. So we used the agent values to do the cutoff. So we had all these and then had to have a cutoff to see which ones are those that actually really predict this data. So in doing that, we had to drop all those survey items which were less predictable of these outcomes. So those were all dropped. And then we came up with a new kind of questions which we think really should help us. So some of those we looked at was, you look at the number of users, so you look at the number of people using the shared facility, and then the restriction to the different households within the same compound. We also then looked at also the accessibility, we looked at facility location, and also went and looked at maintenance. How often is it cleaned, and do we have a schedule for cleaning them? And also went ahead and looked at dignity. So this was helpful on those were our key question domain. Now, based on these questions, then we came up with the performance. So what we did here, then we came up with a score. So the scale score we came up with, based on those, we actually see that we can see overall that 71% of all the households, which about of this, actually had high quality shared sanitation, and 48% had low quality shared facilities in the countries all put together. And then we looked at to see the variation between these. So what you see here, I'm showing you for India, and you could see those of low quality fall around that, and these for high quality. The same thing happens for other countries. So then what we needed to do, as I summarize this talk, is we looked at the specific country distribution of people using this to know which one is low and high quality. This is what we saw in India. So looking at India, all the households we really surveyed, about 1,900, 72% actually had high quality, whereas 28 did not. When we came to Uganda, we actually saw 40% only had high quality shared, looking at those domains we used. And for Kenya, only 25 had the high quality shared sanitation. So this was great for us to make sure we can come to that. And then we had spent some time trying to stratify these. So what we saw in this study, as I summarize, the households are more likely to have high quality shared sanitation if, and these are other kind of stratified things we looked at. If they have higher income, we probably say those are going to have high quality. They own their home that they live in, and also have longer residential tenure in that area. But then we also saw others that their households are less likely to have high quality shared. If, for example, they kept animals near the residence, they had large household size, and they have to pay for sanitation. So in a nutshell, as I summarize, this is my last slide, is what do we get from here? What we see is technology. If you have facilities with flush to pipe sewers, septic tank, composting trays, and all that, you probably see that they're performing better than when you have pits with slabs. The thing we found is materials. If they are easy to clean the floor, and you have water for cleaning and have functional locks, you're likely to have strongly improved performance. The other one you saw is the sharing. If the performance decreases with the number of households as they increase. So every time you see more households sharing the facility, that we need to do more study to see the real cutoff, and that's why we're doing more piloting. And then the user type, look at the public facilities, perform worse than all those. And lastly is the maintenance, which is having responsible cleaners. So this is what we see from here in our study, and therefore implications for monitoring and for policy and practice. What we say is this sample, while we say scale, can provide variable insights into the user perception and experience of shared sanitation. So we feel it can help you do that. It also custodians of the shared facilities, including the users and others, can actually look at this and help them improve the experience. As also look at the scale can serve as a monitoring tool for practitioners and researchers to track changes in these shared quality. And lastly, is the scale can be combined with other tools to actually assess user experiences and explore impact of shared sanitation, and also more field work to make sure we really understand this better. Many thanks to the entire team that we work with, but also to the country partners we work with, the funders, and all that. So thank you so much.
Thank you, Dr. Manga. So up to this point, we've had a few important things. We now know the evidence related to health outcomes associated with shared sanitation. We have a sense as to how to measure shared sanitation, how to distinguish between low quality and high quality facilities. What you might be wondering now is, what does the provision of shared sanitation interventions look like in realities? So I'd like to pick us to hear from implementers in the field. So I'd like to welcome back Sam. Sam will be talking about the realities of implementing shared sanitation on the ground. Over to you, Sam.
Okay, thank you. I just want to start actually by offering a retraction. I think in this post-truth world that we're moving into, it's important to be open when you get a statistic wrong, which I did in my opening, because I think I said 1 billion people dependent on shared sanitation. In fact, it's 570 million. You should trust the JMP, not me as an individual. What I meant to say, I should have been looking at my notes, is 1 billion people living in densely populated informal urban settlements. So we might consider that the potential population using shared sanitation, but in fact JMP 570 million. But I think the point stands, this is not a niche concern, over 500,000 people globally. So it's great to be going after Musa and that fantastic presentation, because I can try and draw some linkages with the intervention in Maputo. I'm going to focus this on really the implementation model that has delivered the results that Joe outlined. But just very briefly, a recap on this intervention. So these facilities that delivered the MAPSAN results, they were constructed 2015-16. WASUP implemented this shared sanitation program. Approximately 300 compounds received improved toilet facilities. This is actually overall, this is going slightly beyond the MAPSAN results, but within this time frame. And those included shared latrines for compounds with fewer than 21 residents and communal sanitation blocks for larger compounds. So it was a mix of those two types of facility. And as a reminder on the technological approach, this was replacing pit latrines with pour flush toilets connected to septic tanks with soak-away pits for liquid effluent. But moving on then to key features of the implementation model. I mean, this font is quite small, but I'm going to talk through it. I hope you can see it. So the first point is site selection. So this was critical. This is based on 12 criteria, which were formally agreed with the municipality, CMM. So you see these criteria here. Of course, the first point is a needs assessment. There needed to be existing but poor quality shared sanitation, and we have photos that demonstrate this, but genuinely very obviously poor quality and a massive improvement that came about. Willingness of residents to contribute financially, and I'll say more around the financial model. Suitable groundwater level for septic tank installation. And the exact location of the communal sanitation blocks was informed by that needs assessment, and it was led by the local leader, the chef de Cortorao. So important to keep in mind that in Maputo there is quite a devolved municipal structure, from district to borough to block level, and all of those levels of the municipal structure were engaged in this intervention and very visibly giving their support. And that included a financial contribution. So there was a 10% contribution from CMM to capital costs, but their contribution actually was greater than that. They provided land free of cost because this was their land. They waived charges for the planning process, and as I mentioned, that 10% contribution. Another important point to keep in mind is that this was not only a shared sanitation intervention, in fact, and it was building on the foundation of water network extensions that had already taken place. So WASUP had been working with ADM, the utility in Maputo, for a period of years to extend piped water networks into these areas, and that enabled then this intervention to move towards pour flush latrines to septic tanks. Disability inclusion, of course, was critical, so there were provision of ramps, separate compartments for use by people with disabilities, as well as gender inclusion, which I'll come on to. And this integrated approach included water supply, but also hygiene. Again, our analysis of this is ongoing, but it may well be significant within this that there was a concerted effort to promote hygiene practice, as well as the appropriate use of these facilities, and those activities were embedded with local authorities at the borough level and building their capacity around hygiene monitoring. And finally, sustainable community-led arrangements for operations and maintenance. And when I mentioned at the beginning that we have the knowledge around how to deliver shared sanitation, I would spotlight this point. I think we have the knowledge of sustainable operations and maintenance. And if you visit these communities in Maputo and you see these facilities, it's very obvious that they are very well maintained. And I'm going to go into how that has come about. So in terms of the model for operations and maintenance, so the first point is that the local borough administration, they devolved or delegated management of these facilities to newly formed sanitation management committees. Those were 5 elected representatives from user households. And there was a lot of work in ongoing community development led by WhatsApp, community development specialists, in mobilizing demand for these facilities, raising awareness around how to maintain these facilities, and that included training of the sanitation management committees. CMM, the municipality, also involved in that training, including on facility usage, O&M, hygiene. And then we come to costs. So an important point is that O&M costs continue to be fully covered by the users of these facilities. The amount varies per facility, but generally it's around $1 per person per month, and that is coordinated, overseen by these sanitation management committees. And Ian Ross at London School has done analysis on the costings and looking at with amortized capital costs over a 15-year period, and that amounts to 4 cents rather per person per day for shared latrines, 10 cents per person per day for communal sanitation blocks. And finally, really important point in terms of the maintenance of these facilities, women have adopted a central role in all stages of the planning and management process. And we have publications specifically on this point because I think it's a really clear example of what gender inclusion looks like in practice. So women have been central to all stages of this process. That includes in needs-based siting and informing the siting of these facilities, which of course is very important in terms of security. Women-led design clinics, again informing those security arrangements, of course menstrual hygiene provision. Women were involved in construction of these facilities, and more broadly this is a factor in the financing model. So communities did contribute to construction, they contributed labour, and women are central to the management of the facility. So over half of these sanitation management committees have a woman president, 2/3 have a vice president, and 2/3 a woman treasurer. So bringing all of that together, and our analysis, WhatsApp as the implementer, I emphasise, is very much ongoing, but to share some emerging learnings or what we think the sector can take from these interventions. First point is that municipal governance structures, of course, must be engaged at all levels. They must display visible commitment to these sanitation improvements, and CMM absolutely did that from the inception and backed that up with a contribution to capital costs and the land. Sustained community level of engagement, and I don't want to undersell the level of work that went into creating demand for these facilities and user awareness of how to maintain these facilities. So that did require community development specialists working with these communities, building trust and being there over a period of time to help them work through issues. High quality of facilities can contribute to demonstration. So of course, this is something that we talk about often, I think, in the sanitation sector, and I think it did play a role in this case. Again, if you see these facilities, they are visibly high quality, and we think that played a role then in catalysing demand, users seeing those facilities, feeling like there was proof of concept, and then wanting to contribute their own costs to being part of that and having access. Siting and design clinics can support the tailoring of facilities to user preferences, with particular attention to the needs of women and girls. And to close again on this point of integration, as I say, it would be wrong to conceive of this as only a shared sanitation intervention. It really was an integrated sanitation, water supply and hygiene intervention in these areas over a period of years. And that is essential also in terms of building community capacity. So there were activities around community-led hygiene promotion and monitoring. The communities are still now moving those activities forward. I think all of that has led to the sustainable operation of these facilities and ultimately to the results that Joe presented. Okay. So I'll close there. Thank you.
Thank you, Sam. So now, the provision of sanitation services in general involve really a systemic approach. We all know that. And governments usually can play a really central role in ensuring scale and sustainability. So I'd like to invite our next speaker, Barbara. Barbara is from the Kampala City Council Authority, KCCA, they call it. And she'll be talking about the realities of implementing shared sanitation from a city management perspective. Barbara.
Thank you. Good morning, everyone. My name is Barbara again. I mean, after Dr. Musa's presentation, so no pressure on the results that he shared. So I will be presenting KCCA's take and how we've implemented shared sanitation in the city. So just to give a bit of a background about Kampala, it's the capital of Uganda and it's a social hub, it's an economic hub. It has a resident population of about 1.8 million people, but this population increases during the day, it doubles. We have lots of people that come in since it's a business hub. Most of their businesses are in Kampala, so that doubles and it puts pressure on the existing sanitation infrastructure. And it also contributes 65% to the country's GDP. And just to give a background also about KCCA, and Sarah said Kampala City, but it's Kampala Capital City Authority. KCCA is mandated by the central government to administer the city on behalf of the government, and it's made up of two leaderships, the political and the technical. So the political is led by the Lord Mayor. He helps us with the political aspects of managing the city, and then the executive director leads the technical side. And KCCA is made up of 10 directorates. And out of those 10 directorates is where the Directorate of Public Health and Environment exists, which is mandated to manage the sanitation in the city, but not just sanitation, but also the medical side of it, the health centers, the hospitals, yes. So KCCA also has a split mandate with National Water. National Water is a national utility that manages the sewage sanitation. So KCCA focuses on the on-site sanitation, that is the toilets, the latrines, and anything on-site. So just to give a background on the status in informal settlements, not Kampala, but informal settlements, we have about 60% of the residents living in informal settlements, and safely managed sanitation was at 56%. This is 2019, not right now. And some of the challenges that we faced, we had about 90% relying on sanitation, on-site sanitation, since a small percentage are connected to the sewer. So, and 85% of these used the pit latrines, but not the pit latrines that we know of, the standard pit latrines. That's the ones that were not emptyable. So we had issues of abandonment because the latrine would get full, they were not aware of the emptying, and the structure is not good, so they were abandoned and moved on to something else. And there was a low collection efficiency, the private sector wasn't involved, and the communities were not in sync with the private sector, so those are some of the challenges that we faced. So we, together with Dr. Musa, conducted a survey. He presented most of the findings, so I'm not going to delve deep into that. But on our end, we also wanted to see how many users are sharing these toilets in the communities, and out of these users, how many of the households, how many are the users, what's the dominant type. From our survey that we did in 2017, what is the dominant type right now? So this was conducted in about 27 parishes in Kampala in the 5 divisions, and we looked at 6 parishes per division, and it was collected using the M-Water application. So on to the results. These were presented, but I'm still going to go into it. 93% are shared, as from the presentation by Dr. Musa. We're not faring very well in terms of quality. but there is great improvement from the previous 8%, 8 households using the same facility. We're now at 6 households sharing a facility, and we're also down to about, on average, 36 users and about 10 users for the lowest division, so an improvement on our end. And we've also seen that 80% are in the same compound. This means that it has reduced on the impacts of having outsiders coming into the same compound, which also poses a health risk on the disease prevalence. So, and also we have, moving down to the hygiene, 77% were clean with no visible FS, which is good on our end because before we were reporting latrine abandonment. But the fact that they can clean the toilets and use them, they empty them, they're connected to the service providers, that is a good improvement on our end. And there's rotational cleaning done by the users who are within the same compound. And the issues of safety and privacy, it was good to note that a big number of them felt safe while using the toilets. They were lockable, they had lights at night, and there were provisions for MHM, which we are also focusing on. So on to some of the interventions that have contributed to the improved sanitation. We developed minimum standards for toilet construction. Now these minimum standards are like a handbook of what a toilet should be. It should be emptyable, it should have hand washing facilities, with soap, it should have privacy aspects covered, lockable doors, light. It should have inclusive provisions for the PWDs, for the women. It should also have a durable and sturdy structure, and it should be secure and safe at night. So we develop minimum standards that have been populated in communities. Now these help construction companies construct the right toilets for their communities. That way improving sanitation. Then we also had the household improvement subsidy. This we implemented with Water for People. And the goal was to improve sanitation from 11% to 50%, targeting 200 landlords in the 5 divisions. Now it had 4 financing options. We had the 100% subsidy, where the toilet was constructed solely by the organization for the vulnerable, the older persons, the PWDs. So that was 100% fully paid. And then we also had the loan financing. So these were getting their financing from the bank through a wash product financing component with the bank. They had agreements with the bank. And then we also had the installment payment model, where a household can approach the implementer was Water for People, and we used a subsidiary. So this subsidiary would get in touch with the household and they make a down payment. The household agrees, okay, I'm going to pay about 60%, then you can pay the 40%, but this is done in installments, not all at once. So the installment model as well, and then the market maker scheme using a local entity. So the average toilet cost was about 10.1 million, which is about $2,900 for the high water table toilets. And then those in the low water were about 8.5 million. So from that, we had about 288 stances constructed. And when I say by trained masons, I mean we also had to build the capacity of the small-time local entrepreneurs that were into toilet construction. Had to build their capacity. The toilet is supposed to be of this standard, and it should meet the criteria. So we had about 288 stances constructed, serving about 656 households, a big number, and that number of people were also served. Then we've also done, and we're still doing continuous sensitizations and inspections through our BCC campaign. We have a Wayonje campaign that runs in the community. Wayonje loosely translates to clean yourself, and it focuses on 3 key aspects: build it, use it, empty it. So build a toilet that meets the standards, use it the right way, don't dispose solid waste. And you might think I am lying, but we have found mattress thrown in a toilet. So it's clear, and it's important to emphasize use it the right way. And also when it gets full, empty it. Contact a service provider to have it emptied. So we encourage toilet construction through our campaign, and we've had about 511 new shared facilities in 5 years of implementing this campaign. And we've also increased awareness on toilet standards. If you look at this is a before. It had a small ladder there. So the ladder was removed at some point and put back. So these are the kinds of toilets that were in the communities. But over the years, we've had improvements. We have some opting to use saddle pans to reduce on the solid waste in pits. And yes, so we have study structures in place. And that's how we've been able to improve the quality of toilets. We're not done. We still have a long way to go because this is still happening. It should be better. We still have a long way to go. And I know together we can get the 40% to 70% at least. Thank you very much.
All right, thank you so much, Barbara, for that. I'm sorry that my results showed Uganda not to be the best, but all right. I think we are going into the most exciting part of this side, which is when we get a chance to engage with the audience. So today what we've done, we've got panelists. We're going to have a panel discussion. And then they have quite hot questions going to them, and then the rest of the questions are going to be from the audience, targeting them. But other people actually may help on that as well. So allow me to welcome Susan from Osprey on the panel, John from Habitant from the panel, and Lina from... We have about 35 minutes, and we want to use them effectively. What we need mostly is to engage, because we're seeing a lot of emerging evidence on mobilizing and recognizing shared sanitation and its importance. But I want to have the panel kickstart some of these discussions, and then we'll go to the audience. And I think my first question will probably go to Susan. We understand Osprey Foundation has been supporting and is supporting and funding shared sanitation. How can we engage other funders, not just from the wash sector or other sectors, to really fund or support shared sanitation?
Well, thank you for the question, and to all the presenters and organizers of this, I think, very powerful and effective session. And just a little bit of a background on the kinds of opportunities that the Osprey Foundation looks for. We really look for opportunities where there is a strong need for catalytic leverage, and where that catalytic leverage is applied against interventions that will have impact, the high potential for impact and scale, but really most importantly also strengthen systems, whether they're market-based or government-led. And so those are some of the criteria that we look for in the types of WASH programming and activity that we support. We're comfortable being some of the first money in when those conditions exist. And so container-based sanitation has been one of those areas for Osprey for a long time. And our foundation has provided both financial and non-financial support to container-based sanitation grantees and sort of this space in the sector for a long time. We've worked with Soil, Fresh Life, and others to really raise the profile and to help iterate the model for increasing scale and impact of shared sanitation options. So when I sat in this same room actually 2 years ago and listened to these presentations, the initial MapSan study, I was, I tell people I was blown away. I was like, wow, this is amazing, right? And what are the barriers, right? We know that shared sanitation, we know that container-based sanitation can be safely managed, it can be dignified, it can be affordable, it can probably even have a higher likelihood of being climate resilient. But what are some of the, but it can only do that if it's high quality, right? And I think sitting here 2 years ago, really, and working more closely, I think, with all the groups in the room over the last couple of years, it was clear to me, and I think to my colleagues at the foundation, who decided to invest really and become the first, I think, investor in the pilot work, Dr. Musa, that your team is doing alongside Habitat, was removing that barrier, right, to what it can be an internationally accepted definition for shared sanitation that can be compelling enough, right, to the JMP and to the policymakers that we need to drive further investment to shared sanitation, right, and to sort of get justice, I think, for the people who are using these facilities and it's their only option. I think with the findings that you were presenting on MapSan, with the impact on sort of quality of life, housing, that these kinds of sanitation interventions brings, we need to, I think what we're all arguing here, we need to go to other sectors and say there are health impacts here, there are quality of life impacts here. We need to educate, inform, influence, and I think getting a definition of shared, internationally accepted definition of shared sanitation, having that recognized, acknowledged at the international sector level, I think it will drive investment. So that's why we're doing this.
Thank you so much. In responding to the question, one of the things that came up was Fresh Life, and you indicated you've been supporting Fresh Life, and we're lucky to have someone from Fresh Life. And along those lines, I want to find out from Lina from Fresh Life, why is shared sanitation necessary in the context you're working in?
Yes.
Because I understand you're working in Kenya and others.
Yes. Absolutely. Thank you for that question, Dr. Musa. So Fresh Life is a social enterprise, and we have been operating in Kenya for the past 14 years, and most recently also in Zambia. And the context in which we operate is exactly what we are talking about today. It's urban, informal settlements. It is densely populated areas. And there are really three factors that I want to highlight here today for why shared sanitation made sense to Fresh Life for those contexts. Some of them which you have heard already, but I want to start with the aspect of just land and planning. So for example, when we take the example of Mukuru, which is an informal settlement in Nairobi, this is where Fresh Life started its operation, we can see that most of the residents do not own land in that area, or no formal titles. So really, most of the residents are renting, and even when we are looking at the physical spaces, we can see that it is they're very small plots. The pathways are very narrow, so there simply isn't space to have every household with their own toilets. So it was very clear to us that physical space is something that is already challenging in those contexts. The second factor that I want to highlight here is just looking at economics and costs. It was very clear to us that we did not want to provide options that are going to be financially unreachable to the residents that we are working with. So it was clear that we needed to think about an innovative way of spreading the costs. So when we're thinking both about the infrastructure, but also as we've talked about quality, we need to think about the aspect of maintenance, cleaning, and for Fresh Life, there's also an additional aspect of collecting the waste as we have container-based toilets and treating it. So it was very clear that we needed to spread that cost among multiple households to make sure that what we are offering is financially just reachable for residents. The last aspect that I want to highlight here is looking at the service model approach that Fresh Life takes. So as we have mentioned, for us, we go beyond thinking, well, here's the infrastructure, and here's 5 to 10 households who are able to have access to it, so that's where we stop. It's really not how Fresh Life wants to approach it. We really wanted to push it to making sure that we are providing safely managed services. So in addition to the infrastructure, we want to make sure that we are working with entrepreneurs from the area. Now we train them on how to operate the toilets, so we know that the toilets are cleaned daily. We also want to work with sanitation workers who are Fresh Life staff, also coming from the community where we work, and they're the ones who are responsible for the daily collection, for transporting the waste. And the very last aspect of it is that Fresh Life also treats, we work with our partner organization called Hygiene, and so we make sure that the waste that we have, the solid waste, is transformed into valuable product. So for us, we wanted to take that extra step and say we are able to provide this service end to end, and it is truly safely managed throughout the sanitation chain.
Thank you. Thank you so much. What I'm getting here is you're doing a lot of work, and this is really trying to move for making sure we even have it safely managed throughout the entire chain. Thank you so much. But I want to move to John now. I understand Habitat is funding shared sanitation, and you've really supported some of the work we do. But how does this align with Habitat's goal for providing affordable and quality housing? In 2 minutes, could you tell us, how does that?
Yeah, thank you very much, Dr. Musa. Habitat is an organization that is focused on housing. And everybody knows that you can't have a house without water and sanitation. Habitat's aim or vision is to see a world where there is no anybody left not having a place called a home to be. And if you look at the situation in the world today, we have over 1 billion people living in informal settlement and slums. And I've fact-checked this data, so this is correct. What is happening is that most of these people are actually living in places which are prone to disasters because they've just moved into the city and they have no places to live. So do they have these services? No. Can we all testify today, if you woke up from your room and you did not use the bathroom for 2-3 days, would you be still attending this conference? No. So Habitat sees this as a big opportunity to help address the issue in the informal settlements where lack of water and sanitation is a big problem. Now, what is even very interesting is that out of this 1 billion, 50% of them are children. And it is estimated that by 2050, we would have 1.5 billion of those children living in informal settlement. When is the time for us to start addressing the fewer children? Is now. So that is why Habitat is focusing on its main goal of providing homes and also providing access to sanitation. And currently, Habitat has a global campaign, a 5-year global campaign, which we say home equals. And mathematics, if you say something is equal, that means the right-hand side has a lot of things. So home equals health, education, everything. And Habitat is addressing all these informal settlement needs, access to basic services through the Home Equals campaign. And we can't do it alone. So we need partners, and that is why we are looking for Osprey, looking for Fresh Life, and all of you to come together so that we can address this. And together, we can make informal settlements a livable place. Thank you.
Thank you so much, John. I like the last statement of together we can make our informal settlement a better life. At this point, it's not here to listen to what they have to say. We want to listen to the audience, and this is the time that we're going to respond to any questions from the audience. If you have a kind of a question that you feel you want us to look at or address, we're more than happy to do that, and this is the time.
That's for the panel or also for the presenters?
Even the presenters.
Good morning, everybody. My name is Preeti, and I'm from Water in Nepal. So I wanted to ask, there was a presentation about the quality of, said sanitation. So in another presentation, there was also about the communal toilets, right? So I want to understand, if the quality of the sanitation is similar for the indicators, are same for the shared sanitation and communal. Why I'm asking this is because in Nepal, under one of our project, we have built 3 community toilets. And also for the said sanitation, I want to ask, because you said that it should be like 5 households. So how many cubicles are there? Because under the project, the community toilets that we have built, we have 10 cubicles. And it's like more, we are serving to like 10 households, the community toilets. And in our experience, the community toilets has been a stepping stone towards the universal access to sanitation, because most of these toilets are built in the informal settlement, particularly the marginalized and Dalit communities who do not have land ownership. So yeah, that is what I wanted to ask, like, because when you talk about the quality standards for the shared toilets and the communal toilets, do you mean it's the same, and how many cubicles are there? And also in our experience, what we have felt is more than technology, it's the management structure, how it has been managed has been more successful. Thank you.
Great question. I am the moderator, so I'm now, someone has to invite me, but let me respond to your question, because I was going to ask someone else. So, the data we have is from 3 countries, and that's why we're saying we're still piloting this. We've just given you preliminary results that we just finished collecting in August. So we've just spent the last 4 weeks, and that's what we presented, but we're digging into that to really see the number of stars and people using them, and we're still doing that. But what we said is there are some key factors that contribute to quality shared, which is not just having the 10 stars, but all other operation and maintenance and cleaning it and all that are really contributing to that. But maybe the next time we meet at the Water and Health Conference, we'll have more for you.
Thank you. Jan Willem Rosenboom, and I have a question for Joe in his presentation. When you showed the result, and I can't tell you how exciting those are to me, but you showed the 5-year results. Am I right in assuming that the year 1 and year 2 results were different from the year 5 results? And if so, what explains that it takes so long for these results to show up? Do you have an explanation for that?
Those are great questions. Can you hear me? So one of the challenges of doing long-term health research in a setting like this is that the population changes quite a bit. People move into and they move out of these communities. So it's really hard to follow people who are in one place for long enough to measure really distal outcomes like growth and impacts on stunting. So one of the things that we observed is that in doing longitudinal research here is that between time points, if you go back a year later, about a quarter of the people have are different people at that point. So so that explains some of why this is sort of difficult and why we need to follow for a long period, is because to get enough people who are present, you have to account for population churn. Now, we didn't see results that were positive. In fact, there was no difference between the groups at 1 year following the intervention and 2 years following the intervention. When you compare all of the children who were present at those time points. But you have to remember that if you go back, so a year following the intervention, that cohort is then composed of kids between the ages of 1 month and 5 years. Most of them had not lived their entire lives exposed to better sanitation. So we saw some findings, and I won't go into them, it's complicated, from the baseline year 1 and year 2 studies that suggested that among the subgroup of children who were born into these better sanitation conditions and lived their entire lives in better sanitation conditions, that they were markedly different in terms of enteric pathogen exposure profile as well as growth. And that then was the justification for doing a 5-year follow-up that would be composed only of kids who were born into and who lived their entire lives under those conditions, essentially allowing us to really examine what the influence of sanitation is on basically complete exposure to the intervention from birth, essentially. And I think that goes a long way in explaining why we saw those results. It's sort of a different cohort of kids at that point, right? And you follow them for a really long time. So I really credit the foundation for giving us a number of years to go back and do this work. Unfortunately, it's really uncommon to have very long-term follow-up in studies like this, as you know. I hope that helps.
Thank you.
Thanks, Natalie X. from Johns Hopkins University. The epidemiologist who wants to continue on this thread, Joe, but I'm going to go back to Fresh Life. Your success has been amazing to watch just from afar. And I'm really fascinated by your model of, as you mentioned, daily cleaning. And I would love to know, right, the biggest difference between these pit latrines with these soaking pits that we're seeing in Maputo is that you can just put more in it, right? And when you have these smaller containers, it really hinges on the success of this daily cleaning. So can you just give us the real deal on what, that's probably, how is it hard to maintain that? And how, what are the success points that you have seen are critical here?
Yes, thank you. Thank you for that question. And yes, absolutely would love to be honest here on what's going well and the challenges that are on the ground. But as I was mentioning earlier, the model here that Fresh Life uses is that we will partner with entrepreneurs who are coming from these areas where we are working, and we call them operators. And so many times these can be landlords. But we also work in settings where it is we are in market or school. So it will depend who the operator is. Will depend, but something that Fresh Life does is we make sure that we are working closely with them, that we also train them on any aspects of daily operation of the toilets, and emphasizing the aspect of cleanliness and every other aspect that will allow the quality of the infrastructure in the toilet to remain a high standard. And in addition to that, there's also the operations that you're talking about, where we have sanitation workers who are Fresh Life staff who will be responsible for collecting, it's pretty much emptying the containers. It's often on a daily basis, and that aspect also had to come with a lot of training, making sure that those services are professional. And yes, we do encounter challenges, but we are really glad that over our 14 years of experiences, we have had the opportunity to learn. So we definitely have challenges around containers not being collected sometimes, or spillages, and we have had to think really strategically about day-to-day on the field, why are those challenges occurring? How can we make sure that we are continuing to learn from some of those challenges? And today what we are seeing ultimately is that we want to continue to just learn from the experience, and making sure that every time that there is a challenging case that occurs, we really get to the bottom of it, like you're saying. So it's definitely a lot of conversations, partnerships between the Fresh Life sanitation workers, the operators, but ultimately, I think it's truly is that's teamwork that allows us to maintain those services.
Hi, thank you. This is Nuhu. My question is very much open. Musa, you can lead to anyone. So about the financing mechanism of operation and maintenance of this system, number one, and what are the backup plan for the climate vulnerability and sudden climate effect, in coastal areas and also in areas where flood and drought. Those are very much important to actually. Water access is one of the biggest challenge for toilet cleaning. So how you recommend those things? Thank you.
Thank you so much. No, actually, I knew you were going to send us tough questions. But the first on financing, I think, would love KCCA and Ruthie talk more on that because she's been in a container base they're doing involves kind of financial models. So Ruthie will probably use a minute to talk about that. And then about resilience, climate resilience, that would go to Sarah to use 1 minute to talk about it.
Me first.
Yes.
Hi, I'm Ruthie. I also work with Fresh Life with Lena. And in terms of the financing for operations and maintenance, so we could go back in time and just quickly have all of you attend our session yesterday. We dug a little bit more deeply into the breakdown of CapEx and OpEx. But I guess the short answer, I would say a couple of things. One, our users pay what is attainable for them. We collect revenues from our users, and we think it's really a substantial amount given what our users can pay, and it does not cover the cost of providing these services. We think that we are not completely unique, but we are relatively uncommon in how honest we are about that, but we do not think that it's actually uncommon. It is costly to provide these services. It is costly to provide safely managed sanitation services, full stop. One thing I think that ties to Natalie's question and what Lena was sharing is we're really looking for opportunities to drive that cost down. One example is we used to have a team that went out and did quality assurance checks on all of our toilets. So we have sort of the carrot. There are lots of opportunities and support that we give to our operators, and there's the stick. If they're not maintaining their toilet, we lock it from the outside, and it will not be unlocked until we've resolved that issue. We don't like to do that, but that we do that sometimes, I think really sends a message. We're serious. These toilets need to be maintained. However, that team added a cost. And one of the things that we've been able to do in the last couple of years is to train our daily collectors to conduct that, right? They're already going. And so figuring out how we can gradually build the capacity of the people who are already going to those toilets every day or every other day. Sometimes it's beyond their capacity, and they'll get to a toilet and say, things are really bad. And we have escalation protocols for that, but rather than sending another team around, those are sort of examples of the ways that we are tightening, shrinking that gap between costs and revenues.
Thank you.
What fraction of the cost is recovered, roughly?
Fraction. It's under $2 out of
Is it most of it? Is it
No,
small
it is a
part?
very small percentage.
Thank you so much, Ruthie. I knew you would respond to that, but I wanted John to use about 30 seconds to add on that, because I know Habitant usually gets involved in financial aspects of improving housing.
Yeah, I think maybe what I can say, and maybe I would just say it from a general point, is sometimes some of these shared sanitations are in compound houses, what we call a big house where we have multiple families living in. So the landlord would charge a portion of the fee into the rent, and then you pay. So it becomes like the landlord's arrangement. So if the rent was supposed to be like $200, the landlord will now put it maybe $210. So you are paying, but you are paying for full service. It's just like your phone service with data and all those things. So basically that's what also, happens in looking at the financial arrangements. Thank you.
Thank you so much, John. I'm looking at time, and I think we have one question there. So Sarah, could you use 1 minute, and then we'll have a question from Yabwala.
Sure. So I'm responding to the question regarding climate vulnerability, and I'd like to highlight how that could impact measurement around quality. So a lot of shared sanitation facilities usually are, again, located in areas that are informal settlements, slum communities, and a lot of these areas are usually undesirable. So for instance, these communities are usually low-lying in terms of topography, altitude. They're located really close to surface water bodies. So I think that they're, again, really prone to like stressors around climate. So thinking about how to measure high quality, I think a next step that we'll have for our measurement index is to incorporate indicators just around how much more prone, just the disparity that, the disparity around just climate stressors. So like, are they a low-lying communities? Does that make them more vulnerable to climate? Therefore, perhaps, sort of give it a lower scoring if it's more prone to climate. So I think in terms of measurement, that's something that the team could look at in future. Thank you.
Thank you, Sarah. Could you just touch?
Thank you. I have a question for John and maybe for Barbara. And because I was thinking, Barbara, when you gave your presentation, you mentioned some of the issues with existing sanitation is they're being used to dispose of waste. You mentioned finding a mattress. You find all kinds of things in pit latrines. Then you upgrade, and so if you remove an opportunity for households to get rid of their waste. And I was wondering whether that then shows up in the picture of what your environment looks like, that waste ends up on the street, and whether there is any experience or need for addressing this sanitation issue in combination with the larger waste issue. And I was wondering, John, whether Habitat has any experience with that you'd be able to share. Thank you.
Yeah, thank you very much. This is really practical. I mean, we deal with housing, and when you have a house, you generate solid waste, liquid waste, and then your toilet or whatever it is. So we combine waste management into one holistic activity. We have the toilet provision while we also manage the solid waste. We liaise up with the city or whichever group can do the collection, and then they will manage the solid waste. Then the landlords or maybe the house owners would pay. And then the toilet would also be a different management system. So we haven't run into a system where somebody is taking a whole solid material and putting in the toilet, but we've actually helped communities to actually generate income from the waste. And we have had many examples where communities have transformed the waste into building materials, into even fuel, I mean, for their motorcycles and so on. Thank you.
Barbara can add on within a minute.
Thank you for that question. My response is similar to what John has just said, because when this solid waste is found in the pits, it's usually treated as hazardous waste. So it's removed by the company that's in charge of emptying, and it's treated as hazardous waste, and it's usually put in buckets that are big barrels and transported to the dumping bay where the hazardous waste is treated and then disposed of. So the case of the mattress was a bit extreme for us as well, and it was just one case. So we're mostly dealing with the diapers, the sanitary towels, household waste. So the waste is treated as hazardous, treated, and then disposed of. I hope that.
Thank you so much, Barbara. I am looking at time, and we've got 2 minutes. Such conversations, usually time is never enough. But I wanted to go back to the panel, and I want to ask them, within 30 seconds, could you give us your final thoughts? And I'll start with Nina, just your final thoughts.
Yes, absolutely. So final thoughts are, I think at the heart of this conversation for us is definitely the question of dignity, and something that we have really tried to understand at Fresh Life is how can we push this conversation of what dignity and inclusivity looks like in a context where we work, to make sure that we are not only thinking about the infrastructure and quality of the infrastructure, but really asking the question of how does rights to safely manage sanitation look like, regardless of where people live.
Thank you. John, 30 seconds.
Okay, thank you. I think the first thing I want to say is that it's very important to know that shared sanitation cannot be ignored, and we need guidance. Because from KCCA, we saw what they are doing and guiding everybody. So we need guiding documents, tools to guide those who would want to do that. There's also less investment in the sector now in that area. So we need to also work with our authorities to see where we can elevate shared sanitation to in the ladder to be able to attract investors into the system. And then the last one I want to say is call to action. We are going to form a technical group, and I'm looking forward to team members who would want to join us, make this a possibility, because we have 1 billion eyes looking at all of us in this room. You see yourself, you, that we are representing 1 billion. Thank you.
Thank you. How about Susan?
Right, it's nice to be the final of the final words. So, and there's really nothing I like better than a call to action for a just cause, whether it's 570 million people or 1 billion people. And so I think what we need to do is we need to keep removing the barriers to, you know, getting shared sanitation safely managed, high quality, and funded. And one of the things that I think I'm excited about and I see as an opportunity on the funding and finance side is performance-based subsidies or performance-based contracts where governments are ultimately the payers, and also the potential for climate finance for sanitation. So there you go.
Thank you so much. So we've used all the time we have. One takeaway from here is we need to look at quality, high quality shared sanitation as a pathway to inclusiveness and sustainable solutions to people in these communities which are highly populated. Thank you so much.
My apologies for misdirecting. I know.
Very good spokesperson. All the, you're definitely going to ask me because you know, sometimes you get nervous, and I'm just thinking like smiling. Yes, we did. I was like genuinely giddy. Yeah. I was like.
Oh, great.
I was like. I'm looking at you. Yeah. Get in touch with you. Say hello to you during the day.
Glad that you asked the question.
And I like, oh, I don't know if you do. And I think some ideas. We're going to do doing the follow up with like
Okay, how are you?
Oh, it's amazing.
I told you I was not lady of the week.
Yeah.